Hello everyone, I am Cheska Janessa Baldan and I will discuss about mitral valve disorders. But first, let's define mitral valve. Mitral valve works like a one-way door system which allows blood to go in only one direction. The valve is supposed to seal shut and not allow for any backflow of blood into the left atrium of the heart. I will show you a clip of the anatomy of mitral valve, or also known as bicuspid valve. The mitral valve is one of the two atrioventricular valves. It is situated between the left atrium and the left ventricle. The atrioventricular valves attach to the ventricular walls via the chordae tendineae, which in turn attach to the papillary muscles so that the leaflets are held tightly and don't invert to the left atrium. This extended attachment of the chordae tendineae and the papillary muscles is known as the subvalvular apparatus. The mitral valve has an anterior and posterior leaflets. The valves of the heart control the flow of blood in and out of the heart. Specifically, the atrioventricular valves functions to prevent the backflow of blood from the ventricles to the atrium during cardiac systole. Opening and closing of the valves is governed by the gradient pressure across the valves themselves, and the first heart sounds can be heard when the atrioventricular valves close. When you hear the classic lub-dub sound of the heart makes, the mitral valve is contributing to the lub sound. So now, let's discuss mitral valve prolapse. Mitral valve prolapse is a condition in which the two valve flaps of the mitral valve don't close smoothly or evenly, but bulge upward into the left atrium. The leading cause of mitral valve prolapse is myxomatous degeneration and sometimes associated with connective tissue disorders such as Marfan syndrome and Ehlers-Danlos syndrome. For the better understanding of mitral valve prolapse, let's discuss its pathophysiology. In mitral valve prolapse, myxomatous degeneration occurs when the connective tissue of the leaflets and the surrounding tissue are weakened. As what I have said earlier, it is associated with connective tissue disorders such as Marfan syndrome and Ehlers-Danlos syndrome. Myxomatous degeneration results in larger valve leaflet area and elongation of the chordae tendineae, which can sometimes rupture. During systole, the mitral valve doesn't shut close, that causes blood to leak back to the left atrium, called mitral valve regurgitation. During diastole, mitral valve doesn't open enough and it gets harder to fill the left ventricle, and this condition is called mitral valve stenosis. Patients with mitral valve prolapse is usually asymptomatic, but often have a classic heart murmur which includes mid-systolic click, which is sometimes followed a systolic murmur. The click is a result of the leaflet folding into the atrium and being suddenly stopped by the chordae tendineae. If the patient has symptoms, chest pain, fatigue, dizzy spells, and palpitations are present. Diagnostic procedures are to be conducted to diagnose mitral valve prolapse. Echocardiogram is used to examine if there are abnormalities of valve structure, function, chamber size, and thickness. Electrocardiogram to examine if the patient shows dysrhythmias. And last, coronary angiogram. It isn't generally used to diagnose mitral valve prolapse but may reveal the condition when you're being tested for another suspected diagnosis. For laboratory procedure, chest X-ray is used to show a picture of your heart, lungs, and blood vessels and can help your doctor to make diagnosis. It also can help to show if your heart is enlarged. For medical management, Medications are given, such as beta blockers. These drugs help prevent irregular heartbeats by making your heart beat more slowly and with less force, which reduces your blood pressure. Beta blockers also help blood vessels relax and open up to improve blood flow. Aspirin. If a patient has mitral valve prolapse and a history of strokes, physicians might prescribe aspirin to reduce the risk of blood clots. Blood thinners. If a patient has atrial fibrillation, a history of heart failure, physicians may suggest a blood thinner to prevent your blood from clotting. Blood thinners can have dangerous side effects. However, it must be taken exactly as prescribed. Water pills or diuretics. Physicians may prescribe diuretics to drain fluid from your lungs. The surgical managements for mitral valve prolapse are the following. First, annuloplasty ring or simple repair. It is performed to put a ring around the base of the valve. Complete mitral valve repair. The valve gets literally trimmed and sewn back together to have more adequate closure so there will be no regurgitation. If a patient with severe mitral valve regurgitation and can't have surgery, physicians may recommend a less invasive approach called transcatheter valve therapy. The new technique allows the doctor to repair a valve by implanting a device using a tube or catheter inserted in a blood vessels in your groin and guided to the heart. The nursing diagnosis for mitral valve prolapse is ineffective coping related to acute or chronic illness. The nursing interventions are: first, instruct the patient about specific valvular dysfunction, possible etiology, and therapies implemented to relieve symptoms. Include family members in the discussions with the patient. Stress the importance of adapting lifestyle to cope with illness. Next, discuss the patient surgical interventions as the treatment modality, if applicable. Assess the patient's use of appropriate coping mechanisms. And last, refer the patient to appropriate counseling services if indicated. The overall prognosis of mitral valve prolapse is benign. Most asymptomatic individuals are not aware that they have mitral valve prolapse and do not require treatment. Complications associated with mitral valve prolapse include infective endocarditis, mitral valve regurgitation, arrhythmia, transient ischemic event, or systemic embolism. The major predictor of mortality in mitral valve prolapse is the degree of mitral valve regurgitation and ejection fraction. Next, let's tackle about mitral valve regurgitation. Mitral valve regurgitation is a leaky valve which permits backflow of the blood to the left atrium when ventricles contract. The leading causes of mitral valve regurgitation are mitral valve prolapse, rheumatic fever, endocarditis, cardiomyopathy, congenital heart defects, atrial fibrillation, papillary muscle dysfunction from ischemia, infarction or rupture, idiopathic rupture of chordae tendineae, and mitral annular calcification. Let us discuss its pathophysiology. During systole, the valve closes, which means blood has just one option. It is to be ejected out to the aortic valve and into circulation. If the mitral valve doesn't shut all the way, blood can leak back to the left atrium, called mitral valve regurgitation. In mitral valve regurgitation, more blood will leak back to the left atrium in each beat, causing left ventricle overload, increased pressure in left ventricle, and left ventricular dilatation. As a result, left atrial pressure also increases left atrial dilatation, and hypertrophy can be seen. Due to the dilated left atrium, patients may experience symptoms like palpitations and embolism inclined to atrial fibrillation. Atrial fibrillation predisposed to embolism which can be presented as stroke, transient ischemic attack, and pulmonary embolism. As a result of the increased left atrial pressure, the blood from the lungs cannot be sufficiently pumped into the left atrium, and this will cause pulmonary congestion, which can lead to dyspnea, pulmonary edema that can cause repetition, pleural effusion, and pulmonary hypertension. The types of mitral valve regurgitation are the following: acute, chronic compensated, and chronic decompensated. Acute mitral valve regurgitation occurs due to the sudden rupture of chordae tendineae or papillary muscle, causes a sudden volume overload of both the left atrium and the left ventricle. The left ventricle develops volume overload because with every contraction, it has to pump out not only the volume of blood that goes into the aorta, but also the blood that regurgitates into the left atrium. Chronic compensated mitral regurgitation develops slowly over months to years, or if the acute phase cannot be managed with medical therapy, the individual will enter the chronic compensated phase of the disease. In this phase, the left ventricle develops eccentric hypertrophy in order to better manage the larger than normal stroke volume. The eccentric hypertrophy and the increased diastolic volume combine to increase the stroke volume so that the forward stroke volume approaches the normal levels. In chronic decompensated mitral valve regurgitation, the individual may be in the compensated phase for the mitral regurgitation for years, but it will eventually develop left ventricle dysfunction, the hallmark for the chronic decompensated phase of mitral regurgitation. It is currently unclear what causes an individual to enter that decompensated phase of this disease. However, the decompensated phase is characterized by the calcium overload within the cardiac myocytes. Patients with mild mitral valve regurgitation usually has no symptoms, but in severe mitral valve regurgitation, the symptoms are abnormal heart sounds, shortness of breath, fatigue, heart palpitations, and swollen feet or ankles. Diagnostic procedures are to be conducted to diagnose mitral valve regurgitation, and these are echocardiogram to examine if there are abnormalities of valve structure and function, chamber size and thickness. Electrocardiogram to examine if the patient shows dysrhythmias, and last is cardiac catheterization to confirm diagnosis and to determine severity. For laboratory procedure, chest X-ray is used to show a picture of your heart, lungs, and blood vessels and can help the doctor to make a diagnosis. It can also help to show if there is an enlargement of the heart. Medications to be administered to patients with mitral valve regurgitation are diuretics. These medications can relieve fluid accumulation in your lungs or legs. Another is blood thinners. These medications can help prevent blood clots and may be used if you have atrial fibrillation. Mitral valve regurgitation requires surgical or replacement. The following are typical valve repair surgery. It is to remove the floppy portion of the valve and the remaining parts are reconnected. It also includes tightening or replacing the mitral annulus, known as annuloplasty. When repair is not possible, valve replacement is recommended. Artificial valves can be mechanical or bioprosthetic. Mechanical valves last longer but require lifelong administration of anticoagulant medications to prevent formation of blood clots. The nursing diagnosis for mitral valve regurgitation is decreased cardiac output related to altered contractility. The nursing interventions are the following. First, assess frequently for change in existing murmur or new murmur. Assess for signs of left or right-sided heart failure. Monitor and treat dysrhythmias as ordered. And last, prepare the patient for surgical intervention. So overall, the prognosis for mitral valve regurgitation varies based on its severity, whether it be major or mild mitral valve regurgitation. Medications can ease symptoms but cannot reverse mitral valve regurgitation. Surgical treatments have greatly improved the prognosis for mitral valve regurgitation patients. Now, let's discuss the last disorder, the mitral valve stenosis. Mitral valve stenosis is the narrowing of the heart's mitral valve. This abnormal valve doesn't open properly, blocking blood flow into the main pumping chamber of your heart or the left ventricle. The leading causes of mitral valve stenosis are rheumatic heart disease, congenital heart defect, and mitral valve prolapse. Let's talk about the pathophysiology of mitral valve stenosis. During diastole, because of the mitral valve prolapse, mitral valve doesn't open enough and it gets harder to fill the left ventricle, and this condition is called mitral valve stenosis. So there are three main factors in mitral valve stenosis. These are progressive fibrosis, leaflet calcification, and fusion of leaflets or the capillary muscles and chordae tendineae. These factors can result to progressive narrowing, and due to the narrowing of the mitral valve, left ventricular filling is affected, so the left atrium has to contract more. As a result, the left atrium will get hypertrophy and get dilated. Because of hypertrophy, the left atrium pressure is increased, and because of this, pulmonary venous congestion occurs that causes dyspnea. Due to the dilated atrium, atrial fibrillation occurs that can cause stroke, transient ischemic attack, and embolism. As part of the atrial fibrillation, left ventricle doesn't contract much efficiently, so left ventricle filling is also affected. This causes the left atrium to contract more, causing increased pressure in the left atrium that result to the pulmonary congestion that can lead to pulmonary edema. As a result of the increased pressure in the left atrium, sometimes the pulmonary circulation increases that causes pulmonary hypertension, causing hemoptysis. In addition, thinking about the heart in relation to other structures in the chest, if the left atrium dilates and gets really large, it can compress its neighbor, which is the esophagus, causing the patient to have difficulty in swallowing solid foods, which is also called as dysphagia. Patients with mitral valve stenosis have symptoms such as shortness of breath, fatigue, swollen feet or legs, heart palpitations, dizziness or fainting, coughing up blood, chest discomfort or chest pain, heart murmur, fluid build-up in the lungs, and arrhythmias. Just like the previous disorder, mitral valve stenosis has also the same diagnostic procedures. These are echocardiogram to examine if there are abnormalities of the valve structure, function, chamber size, and thickness. Electrocardiogram to examine if the patient shows dysrhythmias. And last, cardiac catheterization to confirm diagnosis and to determine severity. For laboratory procedure, chest X-ray is used to show a picture of your heart, lungs, and blood vessels, and it can help the doctor to make a diagnosis. It can also help to show if there is an enlargement of the heart. For medical management, physicians might prescribe medications such as beta blockers or calcium channel blockers. It is to slow the heart rate and allows the heart to feel more effectively. Diuretics to reduce fluid accumulation in the heart. Blood thinners or anticoagulants to help prevent blood clots. A daily aspirin may be included. Antiarrhythmics to treat atrial fibrillation or other rhythm disturbances associated with mitral valve stenosis. And last, antibiotics to prevent a recurrence of rheumatic fever if that's what caused your mitral stenosis. The surgical managements for mitral valve stenosis are the following. First, the closed mitral valvotomy. It is the introduction of the dilator through the mitral valve to split its commissures. Open mitral valvotomy. The direct incision of the commissures. Mitral valve replacement. If the mitral valve can be repaired, surgeons may perform mitral valve replacement. In this procedure, the surgeon removes the damaged valve and replaces it with a mechanical valve or a valve made from cow, pig, or human heart tissue. Last is the balloon valvuloplasty. A balloon-tipped catheter is percutaneously inserted, threaded to the affected valve. It is positioned across the narrowed orifice. The balloon is inflated and deflated, causing a cracking of the calcified commissures and enlargement of the valve orifice. The nursing diagnosis for mitral valve stenosis is activity intolerance related to reduced oxygen supply. The nursing interventions are the following. First, maintain bed rest while symptoms of heart failure are present. Allow patient to rest between interventions. Begin activities gradually. Assist with or perform hygiene needs for patients to serve strength for ambulation. Prognosis. Untreated acquired mitral stenosis due to rheumatic heart disease follows a slowly progressive course, with the patient remaining asymptomatic for years before dyspnea or sudden deterioration from atrial fibrillation ensues. Once symptoms develop, prognosis worsens significantly. If the patient presents with dyspnea, the 1-year survival rate is less than 15%. I will show you a clip to determine the differences between the disorders. So that's the end of my video. I hope you learned something. Thank you for watching.